So I invite Dr. ANOOP to start the presentation. He will be speaking on transition from manual to phacoemulsification surgery, how to overcome the challenges.
Yeah, hi, good morning all. So, as ma'am said, thank you madam for the opportunity. As madam said, I'll be talking on transition from manual to phacoemulsification. I'll be talking on overcoming challenges. As an SICS surgeon myself who had converted to phaco for the last 5 years, I think if I can do phaco, so can anyone. Who can do phaco? Anyone with a good microscope and a good phaco machine. It's once you master it, it's very easier than SICS. It's just, I always say, to my residents, I always say it's just scalp, chop, quadrant, epinucleus, IA, and IOL, putting the IOL and the visco wash. Anyone who can drive a car and can use both feet and 2 hands can do phaco. Just have to have control over your foot pedal with the right foot, over your microscope with the left foot. Use your left hand for chopping and controlling the nucleus, and right hand holding a phaco. But the main challenge, 3 challenges would be to have a mentorship. You need someone to train you, to guide you, to tell you how to convert from SICS to how to go around. And I was very lucky to have a mentor of my own. She always said the first thing is to observe how a good phaco surgeon does surgery. And you need to collaborate with experienced surgeons. Training and education is very important. Workshops, conferences, and online courses gives a good info on that. And before starting on, you need to practice on simulated eyes, develop skills on artificial eyes or wet labs, and be ready before you start. In my opinion, YouTube videos, there are good surgeons who have uploaded a good amount of YouTube videos. It gives a good hand before you go in. And before we start, there are 3 challenges. To have a good microscope, that's more important than phaco machine. To have a good microscope with a good red glow. It's a surgeon's eye, and use it before you cut. Second thing, the position the patient. You have to keep the patient's head flat before we start. Phaco machine, have hands on, understand the parameters, settings, adjust the bottle height, power, AFR, and vacuum to our own settings before we start. And always have a standard protocols. Every surgeon will have a different set of parameters and protocols. Before we start, we need to understand the machine and have our own set of parameters. My mentor always said you need to visualize the surgery before we start. So you need to know how you're planning to go around before we even touch the patient. Visualize the whole surgery in your mind. Case selection is the next challenge. You have to start with the simple, straightforward cases and progress to complex ones. The ideal case would have a good dilatation, grade 2 to 3 nucleus, no pseudoexfoliation, no other complications. And as I said, ensure the patient's head lies flat. Initial cases should always be done under peribulbar or subcutaneous anesthesia, and once confident with that, move to topical. I feel, in my personal opinion, I feel preservative-free lignocaine drops works better than proparacaine in doing topical. I always use intracameral adrenaline for patient comfort. Before we start, we need to have a backup plan. Whenever we are going bad or when we are going wrong, we need to have a cannula with our side. I always keep a cannula with local loaded. Have an iris hooks or BX ring in case the pupil comes down, Rexis forceps, Vanna scissors, CTR, cohesive viscoelastics, micro scissors and forceps, and a vitrectomy set which is working. Many times when we have a complication, when we try, the vitrectomy set wouldn't be working, so make sure that it's working. And I always keep a secondary IOLs, foldable 3-piece, iris flow lens, and rigid PMMA in case I have some complications. Once we have a backup plan, then it's very easy to go around. Now, next challenge would be to sitting temporally, because most of the people who are going to convert would be doing SICS superiorly. Adjust the microscope and foot pedals according to where you're sitting. Do initial first few cases as temporal SICS. I myself had my first 100 temporal SICS before moving into phaco. Make a clear incision. This is my case where I've done a few, just to show the video, I couldn't due to time limits. So make a clear incision as we do in SICS. Then make a small trench, like we make a small initial keratometry. Then progress to divide and conquer through the clear incision. And once confident, you can always progress to clear corneal incision. But then again, there lies a challenge, because there are two. The way we are going to enter the clear corneal would make a difference in the outcome. You need to enter near the limbus. near the limbus, see the scleral vessels, just make a small puncture, then go in, make a triplanar incision. Initial cases make the wound very small so that it can prevent the wound leakage. And train to use 2 hands simultaneously, because always phacoemulsification is to be done by 2 hands. Initial cases for SICS surgeons, it's very difficult. So I always tell my residents to type on smartphones with the left hand so that you get more control with the left. Next challenge would be the capsular rhexis, because you definitely need a CCC4 doing a phaco. Initial cases, people say you can have a small pupil, but initial cases make a pupil which is at least 5.5 to 6 millimeter. And use plenty of visco to flatten the anterior capsule. And when you have small anterior capsular tears, be ready with your tools. You have micro rhexis forceps and scissors, which helps in increasing the CCC. You can use both bent 26 gauge needle or cystome, whichever works well in your hands. I personally feel Hardy-Pucker rhexis forceps is better than Utrata in making a rhexis. Now, the next challenge would be to do a hydrodissection. I personally tell every of my residents to do both hydrodissection and delineation in the initial cases. The first attempt always through the main wound, let out the visco before procedure, and fluid should come out through the opposite side. And rotating the nucleus is very important. The more you rotate, the more cortex loosens up, and it will be more easy for the IN, irrigation aspiration. Now, taming the nucleus, initially when you go in, aspirate the superficial cortex with vacuum, and start with divide and conquer for early surgeons. Keep the instruments at the bottom of the groove. Direct chop and flip techniques at the later stages. Initial cases, please optimize the phaco power and low and AFR low. Use continuous irrigation while entering. That's the initial tip. Use a long Sensky hooks for routine cases. Blunt and sharp choppers only for dense nucleus division. Now, sticky cortex makes the next challenge. Flush the capsule with BSS after nucleus removal before cortex first, so that the cortex comes out very easily. And it's always confused with epinucleus. Do a hydrodissection again after nucleus removal, so that the epinucleus is loosened up. Bimanual IA with Simcoe, if difficult, you can go over that. Grab the cortex within the capsule. Adequate bottle height should be given so that the bag, posterior capsule is gone down. Fill visco to form the bag, then only move it. Now, next challenge for SICS surgeons will be foldable IOLs. Initial cases start with basic unifocals only. Fill enough of visco to form the bag. Keep the posterior capsule filled. Enlarge the primary wound in the initial cases, because I felt that initial to injection very difficult, because the IOL would be stuck inside the tunnel. So enlarge the primary wound. Check the type of IOL and loading of cartridge prior to surgery, because we are used to PMMA lens, which doesn't have loading of lens. But then most of the lenses have different types of loaders, and we have to check for the type of IOL and loading the cartridge prior to surgery. Manipulate the plunger and injector as the IOL comes out. You have to modify your technique so that it comes down flat. Use the left hand dialer to support the IOL so that it doesn't hit the PC. Hydro implantation and wound assisted delivery only once fully confident. Now, I would like to take a word about viscoelastic substances. Use adequate amount of visco during rhexis and in nucleus management. Each time you come out, fill in visco. It protects your endothelium and your PC. When in doubt, stop the surgery and fill in 2% HPMC. Have a cohesive viscoelastic in case. And ensure that your visco is completely removed after surgery to prevent post-op condylar edema. And my tips for smooth transition is to start with straightforward cases, lower the ultrasound power, monitor IOP and con health, manage viscoelastic carefully, maintain proper surgical ergonomics, stay focused on nuclear emulsification, be prepared for complications, and be confident to convert to SICS in case of any issue. My mentor always tell me properly done SICS is better than complicated phaco. And post-conversion, I'm very helpful for my mentor over here for make me convert to phaco completely. I myself do 99% of phacos, right? All cases, 99% of all my cases are phacos. Please collaborate with experienced surgeons and seek guidance on challenging cases. If you have video recording, record your cases, record all your cases, and have a feedback from that. Peer feedback is very important. Review your own recordings. Participating in peer review and feedback sessions, refining surgical techniques, and it improves, your skill improves on continuous learning, staying updated on latest technique and technologies, attending conferences and workshops. Thank you.